X-rays in children can be quite a challenge in some instances. So we're going to get started, and this is our first poll. So if you go on to Slido and if you scan the QR, you should get different options. And the question is easy. All of you know how to do this. So I want you to tell me what's the age of this child, and just estimate it on the X-ray findings. Okay, so the maturity of the bone will assist you in this regard. And the question again, just what is the age of the child by evaluating the right arm X-ray? Okay, I'll give a few more seconds to imprint this, so if you want to take a picture, you can. All right, let's move on to the basics. So those of you that have done physiology recently, this is a recap of the physial plate or the growth plate, where we get the epiphysis and the physial plate and then the metaphysis. You get different zones in this area, and the area of hypertrophic zone, or the hypertrophic zone, is the area of the most likely injury. And due to the physiological combination of these different areas, this is the weakest part of a bone in a growing child. And as said previously, the ligaments in this area is mechanically stronger than the bone itself. Injuries occur up to 50% of cases of fractures in children, and it mostly involves the upper limbs, so radius and ulna in most of these children. And then, as you know, in girls it happens probably about 2 to 3 years occurrence, lower than or younger than in boys, which is 12 to 15 years. And up to a third of these physical injuries can complicate by having growth disturbance, abnormal growth. So it's important that we know what we're looking for, and it's important that we don't dismiss injuries without having the appropriate imaging and follow-up. Moving on, the next slide, you should see Salter-Harris classification. I'm not going to go into it in too much details. Most of you know the mnemonic SALT R without the E. You can add the E if you want. What I personally found difficult is we tend to remember the mnemonic, but then the above or lower or below becomes confusing when you draw those pictures for yourself. So be sure that you know where the metaphysis is when you take these pictures into consideration when you are asked about the different Salter-Harris injuries. It is unfortunately an exam question as well, but more so for clinical practice when you speak to your orthopedic consultants or your orthopedic colleagues, that you both are on the same page on what you are describing. Secondly, it's a different classification system that is also available. It's called the Ogden classification, and it provides a little bit more detail than a Salter-Harris classification. I don't think we all need to memorize this, but for the guys going into the part 2, it probably is a good idea to just make sure that you know that there is a different classification system, and that you know, if you need to, you can describe a fracture in this regard when you do refer to orthopedic surgery. All right, typical injuries in children. This is an example of a green stick fracture. A green stick fracture is a unilateral cortex fracture. The one cortex stays intact, which is visible in this X-ray on the ulna, and the other cortex is fractured, and it could be angulated, but in most cases these fractures have a good outcome. This X-ray is a little bit more complex than that, but it's just to demonstrate a green stick fracture. Then buccal or torus fractures, where both cortices are buckled, is also a common fracture in children. And then also a bowing fracture, whereby as a reed or a young, well, not really a green stick, but where it bends like a reed without fracturing, And these cases in general are in younger children, and they have a better outcome than most other fractures. When do you reduce them? Well, there's different opinions in the literature, but if the abnormality or basically what you see in deformity in the child is quite significant, suggestion is that you attempt a closed reduction in those children. Also remember to look for other injuries in this case, but again, most of these with a backslap or immobilization for a short period, up to 3 weeks, have a good outcome. Some orthopedic surgeons would leave a tarsus or a buckle fracture without immobilization. Personally, I prefer to immobilize them just to remind the child that there is actually an injury and that they don't re-injure that limb in this regard. Are there any specific questions at this stage before we continue on to the upper limb? Okay, anybody else that needs to have the QR code? I'm just looking at the chat. Do I need to go back to the QR code, or is everybody happy? Okay, I'm going to take that as a yes. I'm just looking at your votes. Okay, so we've got a tie. 44% of you said that the child is 9 years old, and 44% the child is 6 years old. Okay. And we'll go on to cover and explain why the child is actually closer to 6 years old. All right, so looking at the ossification center in children, Cloete is the mnemonic that most of us memorize. If you go according, we'll go back to that X-ray. So you can see the capitellum, you can see the radial head, you can see the internal or medial epicondyle that is developing. Continue, the next one that would develop would be the trochlea, which you can see here, followed by the olecranon, and then the external or lateral epicondyle. So in X-ray number A, we can see the capitellum, the radial head, as well as the medial epicondyle that is, and the other three are not visible. So what you 9 years old is ossifying in this view. Looking at the ages, this is again approximate, and there's no one absolute number. You need to be aware that there's about a year up to 2 years in some instances variation on this number, but the principle is more the sequence of how ossification occurred. So again, Cloete, the mnemonic. Remember, girls you probably trying to win how this child is. So looking at this table, 3-5, the medial epicondyle ossified 5 years, and following that, the trochlea, olecranon, and lateral epicondyle. If you look at the, that is not as straightforward. There's a different mnemonic, although person CTE or CTE-ROI, so CTE-ROI, and that would explain the fusion of these growth plates. The capitellum, trochlea, and the lateral epicondyle fuses first together into a single, and then together they fuse to the distal humerus at the age of about 14 to 16. So as you can see on the next slide, that will just demonstrate how the lateral epicondyle, the capitellum, and the trochlea humerus. Just my slideshow paused.
Flip, is your network still fine? You seem to be breaking up a lot.
Okay. Trying to hear me.
We can hear you, but it's breaking up a lot.
Breaking up a lot. Okay. Okay, let's try again. Let me know if it becomes a problem. Then I'll change the internet access. So this is essentially the slide that I explained, which is the lateral epicondyle, the capitellum, and the trochlea fused together, and that together then fused to the humerus at the age of about 14 to 16 years. Continuing on to the upper limb, this is our second poll, which should be open for voting now. I'm just going to see if the slide changes. Okay. So I would like you to identify the injury that this X-ray depicts. The child fell on a flexed elbow. And for your own learning, you can look at the age of the child as well. So look at the ossification center and identify what the age of the child is, and then also what the injury is in this regard. I'll give a few more seconds for guys to have a look at the X-ray. Okay, so the basics for the upper limb X-rays, two things that I think we need to be aware of. So there's two lines. The one is the anterior humeral line, which is important when we speak about supracondylar fractures. And the other one is the radial capitellum line, which is essentially going from the neck of the radius and should transect the middle of the capitellum. This would show if a radial head injury has occurred. But the anterior humeral line is probably most important, seeing supracondylar fractures is the most frequent injury that we see in upper limb fractures in children. So normal anterior humeral line, the middle third, and if you can see that yellow dotted lines will depict the middle third of the capitellum. If this line is anterior or posterior to this, you need to be aware that there is probably a supracondylar problem or a fracture. Sorry, let me just see if I can get a... Okay. Okay, the radiocapitellar line, as I said, should be drawn from the neck of the radius and should intersect the capitellum. If this line goes superior in that plane, it means that the radial head is injured. If the line does not intersect the capitellum, as I said, there might be a dislocation of the radial head, so be aware of that. Secondly, it should be a true lateral of the humerus, not a true lateral of the elbow if you are interested in diagnosing supracondylar fractures. You can see in this view, I'll see it better in the next, but sort of figure of 8, which will show you a true lateral of the. And then lastly, any posterior fluid, so any posterior fat pad sign is abnormal. There could be some fluid anterior to the humerus, like for example in this X-ray, but any fluid posteriorly is abnormal, and you need to investigate and have a low threshold to that patient. So if we apply the anterior humeral line to this, the lateral elbow or lateral humeral X-ray, you can see that the line does not go through the middle third of the capitellum. It means there is a supracondylar of the extension type, and it is a Gartland type 2, which we'll get to. And you can appreciate the fluid, which is posterior, is visible in the soft tissue, and in general, there's a lot of soft tissue swelling in this view. It's a very frequent injury that we'll see, and the management of this, depending on where you work, you might be asked to, or if you are willing to do a reduction with a little bit of anterior pressure before you mobilize in a 90-degree above elbow back slab. This is another example of a supracondylar fracture, and in this case, the anterior humeral line does transect the middle third of the capitellum. So this is a Gartland type 1 fracture. What you can visualize on this X-ray is again the general soft tissue swelling. Anteriorly, there is a significant amount of fluid in the tissue. This is also called the Sale sign. And posteriorly, you can see a fat pad sign there as well. This is in supracondylar fractures type 1. This is mostly what you'll see. You'll see the soft tissue swelling, but you might not see the fracture itself. Into the Gartland classification. This is important as it will guide you in management. Type 1 essentially has got no or minimal displacement with the soft tissue that's mentioned, and above elbow back slab, and not a slab just above the lecranon, properly above the elbow, which is one close to the body under the clothing and not through the sleeve, is important. And after about 3 weeks, they can have a follow-up, following which they will be mobilized with rehabilitation. Type 2, and you get both anterior and posterior displacement, is essentially where the one cortex, either anterior or posterior, remains intact with some displacement. And as mentioned, you can perform a gentle reduction again in another. But if there is neurovascular compromise in this injury, you might be needing to put the patient in a back slab of about 30 to 40% flexion, and not completely 90%, to maintain that vascular supply. And then type 3 injury is complete disruption, and these need to be seen by orthopedic surgery emergently, as they need to go to theater. They need to be reduced and internally fixated as soon as possible. And then just for interest, the type 4 fracture, which is both periosteal, that's completely disrupted, can only be diagnosed in theater essentially, because type 3 and type 4 might look very similar on an X-ray. So type 2, probably an urgent referral to orthopedic surgeons. Most people will probably get the patient back in the next morning or the day after, but type 3 will need to be managed by them as soon as possible. They might not operate on it in the middle of the night, but they should probably be admitted and prepared for the next theater list. Moving on to the next injury. As you can see, there's a fragment of bone which is avulsed, in this case, from the patient's lateral epicondyle. And in children, it's important to distinguish between condylar fracture. So lateral condylar fracture is more frequent, although both the lateral epicondylar and lateral condylar fractures are slightly displaced, but will respond well, conservative. And okay, can you hear me now?
Yes, I can.
Okay, apology for the interruption.
No problem. We understand.
We were discussing, change the internet supply. So we were discussing this views, just to re-emphasize lateral epicondylar avulsion in this case, but also be aware of a condylar fracture, which you will visualize in this X-ray. So as you can see, there's two bone fragments in this case. The one is a larger fragment, which is the condyle. That's the fracture line runs there, and then a loose bony fragment that is pulled off here. And if you look at the lateral, obviously the soft tissue swelling is quite significant, and you have a loose bone fragment that's sitting superior to the joint that might need to be removed to not impair into the function of these injuries. There's two essential injury types in the lateral condylar fractures in children. One is Mulch, the other one is Jacob. Mulch essentially classifies into type 1 and type 2. I don't think you need to memorize this. Just be aware that the type 2, as you can see, extends intra-articular. One that is probably more practical is the Jacob classification, and that speaks to stage 1, 2, 3. Stage 1 is less than 2 millimeters, where the cartilage hinge is still intact, so no obvious displacement. Stage 2 is more than 2 millimeters, where there's no, or 2 to 4 millimeters, where there's no cartilage intact anymore. And stage 3 is more than 4 millimeters displacement with a rotation of the fragment. And both stage 2 and stage 3 will require operative intervention and fixation. Okay, this is to just recap the management of lateral condylar fractures. Type 1, conservative with weekly imaging and follow-up, and type 2 and 3 needs open reduction and internal fixation. So to continue to the medial epicondylar injuries, you can see the medial epicondyle in this view is displaced. It's probably just under 5 millimeters displaced, and if you only get a lateral, which reminds us to always get two views and compare the left and the right arm. If you only get the lateral view, you might miss this injury. Another example of a medial epicondylar fracture, and in this regard, there's again two fragments, and the displacement is a little bit more, probably between 5 and 15 millimeters, and more than 15 millimeters. And those are the three classifications that we use to assess the severity and again the management of these injuries in children. So less than 5 millimeters, conservative management with 3 weeks of mobilization, and then follow up with orthopedic surgery. Conservative management at 5 to 15, and we'll get to the differences, what is suggested in the literature, when to manage a 5 to 15 millimeter displacement of a medial epicondylar injury conservatively, and when to do operative intervention. And in anything more than 15 or other injuries like intra-articular incarceration, involvement of any other structure or a compound fracture, needs a washout and fixation. What the literature suggests is between 5 and 15 millimeters, conservative treatment can be considered for younger patients under 8 years when it's the non-dominant hand or when there's no or little sports. And in the converse, to fix operationally or surgically if it's older than 8, dominant arm, or if there's athletic activity. My concern with this is at 4 or 5 years of age, you might not be aware of your athletic ability or interest. And also in being in South Africa, where a lot of our workforce are dependent on manual labor, I would actually advocate for our patients to have operative management of these injuries, as in the long run, that will improve their function and their outcome. So getting back to the X-ray we had our poll on, so 68% of respondents said that this is a supracondylar fracture, okay, which I understand, because if you draw that line, it probably still it's probably still in the middle third, anterior humeral, the middle third of the capitellum, but it might be anteriorly displaced. So I agree that is one potential injury, but there's no obvious soft tissue swelling here. Neither is there any soft tissue swelling here. Now, if you look at the AP view and you go through the different ossification centra, you can see the capitellum, the radial head, okay, the internal or medial epicondyle, which is where the problem starts. Okay, you can see the trochlea here, and you can not really see it that well, but you can see the olecranon on the lateral, and then you can see the lateral epicondyle in this view. So if you look closely, this is the medial epicondyle that is displaced quite significantly, probably about 10 to 15 millimeters. And if you look at the lateral, this is the medial epicondyle that's sitting intra-articularly, that's shifted. Okay, so this is a difficult X-ray to interpret, but remember, you need to have a system. Like we have a system for chest X-rays, you need to have the same system when looking at pediatric elbow X-rays, because they can be quite complex. So this is a medial epicondylar fracture, probably about 10 millimeters displacement. And because of the intra-articular complication, this patient needs operative intervention and probably pinning to correct and allow normal maturation going forward. Okay, we're going to continue to the lower limb. Any specific questions? Gowdy, can you hear me better? Is this setup more clear?
Yes, Flip, an overwhelming positive response on the chat as well. It's definitely projecting better. The images are better, and even your voice projection is better. So thank you for that change.
Okay, apologies for that. Okay, to finish off our third poll of the day, AP pelvis of a child that presented to the emergency center complaining of a limp.
Sorry, Flip, before you continue, you just have a hand up from McAlpine.
Yep.
You can ask your question.
Go ahead.
Thanks, Flip. Just a quick question about Gotland 3 supracondylars. Is there ever a reason for us to try and reduce them or get them in a better position or flex them to 90 degrees? Or if, as long as there's a pulse, we basically just put an above elbow back slab at kind of whatever position that arm is in at like 20 degree flexed, and then give it to the orthos? I'm never quite sure how much to try and reduce them or not, if there's a pulse, obviously.
Yeah. So personally, I support your view that we shouldn't be actively reducing a Gotland 3 because of the risk of causing neurovascular injury. And if there is a pulse and no neurological fallout, immobilize them in a position of comfort, being that 20 degrees, 30 degrees, 40 degrees, but I will not force them into a 90-degree position. If there is neurovascular compromise, that might be a different story, and you might be required to have to attempt some type of reduction to improve that. Those cases need emergently to go to theatre if there is neurovascular compromise to resolve that situation. But I know that some orthopedic surgeons will be pushing while they're at home for us to do a reduction of those cases. But my personal opinion is that we shouldn't be reducing Gotland 3s as standard protocol in the EC. Immobilize in a position of comfort and then refer as soon as possible.
Okay, great. Thanks very much.
Okay, cool. All right. So again, child presents to the emergency center with a limp. This is the AP pelvis X-ray. And we'll give a few seconds for everybody to have a closer look at it. I think this should be the easiest of the 3 X-rays, I think, but let's see. Okay, let's continue. So touching on a limping child, again, this is a clinical sort of conundrum that you're going to be faced with. Children coming in complaining of a limp, or mom says child doesn't want to stand on a foot or stand on a limp, and it can be in different, they can verbalize it in different ways. They can say, no, the knee is sore, no, the foot is sore. But if you visualize the child, you'll pick up that there's an abnormal gait pattern. Secondly, be aware that if the parents tell you the child is having an abnormal gait pattern, but you don't think it's abnormal, again, remember what I started off with. If they're worried, you need to pay attention. This is one way of dividing different diagnoses for a limping child, looking at which conditions can appear at all ages, which conditions will be the younger child, 1 to 4 years, then 4 to 10 years, and then older than 10 years. There's obviously other diagnoses that will fit as well, but these are probably the most important ones. Under all ages, septic arthritis is always a condition that we need to exclude because that can have significant prognostic sequelae if we miss it. Osteomyelitis, trauma, and that can be accidental or non-accidental, malignancy, and then pain refers from elsewhere. So knee pain, hip pain, etc. Late onset hip dysplasia for a little bit older children or the 1 to 4 years, transient synovitis, and toddler's fractures, which mostly occurs in the tibia. Then again, 4 to 10 years, transient synovitis still there, Purvis disease, and then neuromuscular conditions, including acute disseminated encephalomyelitis and Guillain-Barré syndrome, although these is generally rare in children. And then more than 10 years, SCFI or slip capital femoral epiphysis mostly appears in the older children, depending on gender, obviously. So you need to have an approach in your clinical practice to the limping child. And remember that this is probably one of the oral questions that will come up in the exam for the Part 2s as well. I had the privilege a few years ago to have to answer to Heike about the limping child. So it's a question that you need an approach to. So our next case is a child that's been brought in. It's about a 3-year-old child, and mother says the child doesn't want to walk anymore. She thinks the child is more miserable than usual, and she's not really sure if he has a temperature or not. But she's taken the child to the GP, and the GP is worried that the child's got a septic hip, and she doesn't know what to do, so she brought the child to you. And this question you'll face multiple times in your career, and you need an approach to disseminate or discriminate clinically and in several ways to discriminate and make the diagnosis of, is this a septic arthritis or is this a transient synovitis? One relatively benign, and the other one, as I said, can have a significant prognostic outcome that can have an implication in the child's health going forward for life. So 2 big studies that you should know probably is the one is Kocher's trial, which was published in 2004, and the other one is CARED, which was published in 2006. The Kocher's criteria, and this is one condition where unfortunately we need to do the septic markers. Clinical exam is very important, the history is very important, but you're going to have to do some special investigations to try and disseminate between the two. Kocher showed that non-weight bearing plus a fever, documented fever, the ESR of above 40 and a white cell count of above 12, If you have all four, it's very likely, and the probability is about 93% if you have all four. If you had 0, they essentially excluded it by saying it's 2%. The challenge with Cocker's original study is it's never been validated by a different group. Caird et al., as you can see in the slide, show that even if you had 0 points, you still had a 16% chance of having septic arthritis. So what they then described was to combine Cocker's criteria and add a CRP. In their study, they found that fever was the best predictor of septic arthritis. And if you add a CRP of more than 20, it would be an independent risk factor for septic arthritis. If you look only at fever plus CRP, personally, I would suggest use Cocker's criteria, add the CRP, use your clinical gestalt, and have a low threshold to refer to orthopedic surgery to perform an aseptic hip aspiration. And by meaning aseptic, I don't mean in a corner at Victoria's EC. These patients generally need to go to theatre, and they need to have a sterile procedure with theatre conditions to do the aspiration of the hip. And if that is then positive, that can be sent for a culture that you can base your management on. Ultrasound, yes, you can use ultrasound to diagnose an effusion of the hip, but unfortunately, transient synovitis can also provide or give you an effusion in the hip joint, and it's not specific enough to distinguish between septic arthritis or transient synovitis. Looking at which bacteria you'll be treating, Staph aureus is by far the most likely organism through all age groups. The younger patients, remember group B strep, which is pyogenes, and then as you increase with the age groups, strep pneumonia, Haemophilus influenza, hopefully with the immunization schedule, we won't see that anymore. And then Neisseria gonorrhea as the sexual activity increases above the age of 12. Cloxacillin is essentially the first line medication, and our South African guidelines suggest cloxacillin 2 grams 6 hourly, or ceftriaxone if there's gram-negative cocci. So the first line of management, if you have a purulent joint aspirate, would be cloxacillin, and then probably await your culture with early surgical washout and drainage. De-escalate appropriately when the culture results come out, and just be aware that the intravenous antibiotic course for septic arthritis is long. It's 2 weeks, up to 4 weeks if Staph aureus is confirmed, and Neisseria gonorrhea up to 10 days. So these patients generally stay a long time in hospital for their IV antibiotics, and they need early surgical washout and drainage to have the optimum or the best prognosis. Right, this is an example of Purvis disease or leg calf Purvis disease. Those are the 3 gentlemen that describe this condition. And in this X-ray, you can appreciate that the femur head on the right is more irregular. The joint space is more irregular and probably less than on the left. This is idiopathic osteonecrosis or AVN of the femur head. And the etiology as of today differs. People have got different opinions, but it essentially comes down to an imbalance of resorption being replaced by abnormal bone, and during that replacement with softer abnormal bone, there's a risk that the femur head can be compressed or can have fractures and then can have permanent sequelae. It is again male to female predominant 4:1. And it's mostly unilateral. If it becomes bilateral, it usually happens in succession, and it doesn't occur simultaneously in both hips. Although it's possible, it's very unlikely. They normally occur to one and then the other. Remember, these can also present with children that has been seen several times. You get frustrated by the recurrent presentations, and the 2 things that they can present with is knee pain, and nobody examines or images the hips. And secondly, a child that's been seen and had several diagnoses of transient synovitis, you need to have a careful look at the X-ray and imaging to make sure this is not pelvis that we're missing. This is a close-up X-ray of the same condition. And there's essentially 4 stages. I'm not going to go through the detail, but initial bone necrosis, fragmentation, where the dead and necrotic bone is replaced by the soft bone as mentioned, then reossification, and eventually with final outcome with bone regrowth. And the several factors would depend on this. The first, damage that happens during the fragmentation phase, the amount of damage is mostly going to determine your outcome and prognosis. Another example, you can see on the left, there's almost no femur head left, and this child is unfortunately going to have probably a limp and some permanent sequelae from this condition. The objectives of the management of this is to try and keep the femur head in the acetabulum for as long as possible to help assist the formation of that round head and to maintain range of motion. Now, to have those two together is quite a challenge, and especially if you look at a child between 4 and 10 years old, it's even more difficult. So currently surgical management is preferred above the conservative management, and the operation of choice at the moment is a triple osteotomy, whereby the pelvis is severed here, both pubic rami are severed, and then the angle of the acetabulum is changed so that it encompasses or fits over that head more, and then it is fixated in almost it's more a lateral rotation of the acetabulum, and then it is fixed in place there. If you look at the child on your screen with the unilateral cast, this child had a triple osteotomy, and that's the cast that was applied to keep that hip in that position. The other 2 are examples of a Petri cast or a Petri brace. These put the hips into abduction, but it's a challenge to mobilize with. So you can imagine this child most left on the screen is going to have a very difficult time mobilizing, even if he has crutches because of the imbalance. The brace in the middle is a little bit better, but it is still going to be a challenge to mobilize and to continue with normal living daily activities. So that's one of the biggest reasons that surgery is currently the preferred management modality. From an emergency point of view, make a diagnosis and refer the patients urgently to orthopedic surgery. So the last condition we're going to look at today, if you look at the left femur head, you can appreciate that it is rotated. If you imagine an ice cream cone with the ice cream on top, it sort of slipped medially. And this is Xafis or subcapital femoral epiphysis. How do you diagnose that? The AP view is the preferred modality. You can ask for a frog leg, but remember a frog leg view can actually displace the head more. So you should probably start with an AP view first and see if you can make the diagnosis. Secondly, you can use Klein's line to evaluate, and Klein's line is looking at the femoral neck and drawing a line in that regard, and it should intersect with the femoral head. On this side, you can appreciate that it will miss the femoral head completely. These children, as mentioned previously, is more than 10 years old. It's mostly males, and of them, 60% or above is above the 95th percentile of weight. So they're mostly obese. And that combination is one of the reasons that the slipping occurs. Up to 50% eventually has bilateral slipping as well. Again, it rarely happens simultaneously. It's first the one hip and then the other hip. And conditions that would predispose you to this is endocrine abnormalities. And those children have a higher chance that they will have bilateral slippage. One of the things that will clinically manifest is when the child walks, they will have an external rotation of the foot and a lateral swing of the leg to try and make the pain a little bit less when they walk. And then also referred pain to the knee, as mentioned, because of the medial obturator nerve that might be involved. So again, if you have children with knee pain, always examine and potentially image the hip to make sure that's not where the referred pain is originating. This is another example of the same condition. Again, the left hip involved, and this is the frog leg view. This is Klein's line. And as you can see, it's not a great image, but a normal Klein's line, the femoral head is crossed, and in this view, it's missed completely on the lateral side. So coming back to our poll, 64% the diagnosis correct. So this is slip capital femoral epiphysis on the left hip. And if you draw Klein's line, you will appreciate that it's going to miss there. Up to a third of respondents chose answer A, which is hip dysplasia. You remember with hip dysplasia, the whole hip would be involved, and it generally occurs in younger children than this. But using Klein's line, you will make this diagnosis. And again, remember to examine the joint above and below in all these cases. So that concludes my talk for today. I'm willing to take some questions. I don't know if there's anything in the chat at the moment. Just remember take-home points. Consider what the parents tell you. They are always right, okay? You need to have an approach to the ossification centers of the elbow in pediatric patients, because that will help you quite a lot going forward. You need to have an approach to distinguish between septic arthritis and transient synovitis, and know how to manage the limping child when they present to your unit. Thank you for your time.
Thank you so much, Flip. That was very informative and definitely a lot of advice that we can take home. There are no questions currently in the chat, so if nobody else objects, I think we can welcome Paul.
Hi guys.
That's fine.
We've got my presenter view. Hi guys, can everyone hear me?
Yes, we can.
Great, great. So my name's Paul Xafis. Let me just start my video. Okay, great. Okay, so today I'm going to be talking about handling hand injuries in the emergency center. It's quite a common thing that we see. And I think everyone, depending on the irrelevant of your level of training, needs to know how to handle hand injuries. So why do we worry? Well, hand injuries compromise 20% of EC visits. They're very important in terms of function because hand injuries lead to work absence, lost productivity, and chronic disability. Early and appropriate management is vital to preserve function, obviously anatomy, and prevent stiffness later on. So most hand injuries actually don't need surgery, about 90%, but most injuries do need to be referred to a specialist for further assessment. Obviously, open fractures, intra-articular fractures, and rotational deformities usually require operative management. So our goals as emergency care practitioners are to facilitate closed reduction, do appropriate splinting, and make sure that the patients are referred early. So in terms of our outline, I'm going to talk, I have a lot of information to discuss. I'm not going to discuss all hand injuries, and I'm going to leave out splinting because Seb or Dr. Dehaan discussed splinting last week. So in terms of our best practice guide, hands are livelihood. If a person doesn't have a hand or they've bilateral amputees, their chances of working or working in terms of manual labor is quite low. So what I want to know when I assess a hand injury is the mechanism of injury, okay, and which hand the patient writes with. So what hand are they dominant with? I want to give analgesia early. So I want to give parental analgesia, whether it's oral or IV or IM, and administer a local block. Examine the hand. We need to know the anatomy. You need to know what you're feeling underneath your own fingers to give you a better idea of what the diagnosis might be. We should always get standard X-ray images, and then there's specific views which I'll touch on for certain injuries. If it's an open wound or a bite, these wounds need to be explored and irrigated under high pressure. Hand injuries should be splinted and elevated, and if you're in doubt about which splint to use, the position of the position of safe immobilization splint or the Posey splint is your best chance, your best bet. Also, you need to refer early. If in doubt, just ask for assistance. So when it comes to assessing the hand, ask the questions. So mechanism of injury, was it a fall on an outstretched hand? Was it an assault, a bite? What is the level of contamination? Get the time of injury, hand dominance, ask about patient comorbidities. Are they immunosuppressed? Are they diabetic, HIV? Are they on immunosuppressants? Any allergies? That's important when we're administering prophylactic or antibiotics for treatment. And NPO status in case they need surgery. Always, always, always ask about tetanus immunization status and administer tetanus toxoid. In terms of high-risk features, so delayed presentation, a lot of our mental health care users or substance users may present delayed, so after 24 hours. Obviously, that's important because delayed presentations are associated with complications such as infection. Psychiatric history, geriatric patients are prone to falling, prone to delayed presentations as well, and then any patient with immunocompromise. So when it comes to examining the hand, we want to look, feel, and move. I prefer to look first, see what I can see. So is it bruised, swollen, is it bleeding? If we have any bleeding, obviously stop the bleeding first and then proceed with your examination. Remember, the hand is not in isolation, shouldn't be examined in isolation. We need to screen the whole limb, starting from the neck, moving to the shoulder, the upper limb, and the elbow. You don't need to do a full examination of the shoulder, just basic, can you move your shoulder, is there any pain, and move on towards the hand. That's where we want to focus most of our attention. So we want to inspect, palpate. I usually start from the wrist and move towards the fingers, palpating everything as I go along. We want to do passive and active movements. So what can the patient do and what can I do for the patient, and assess if there's any discrepancy. Assessing all ligaments, assessing flex and extensor tendons, assessing radial, median, and ulnar nerve functions, and lastly, assessing vascular status, so feeling the ulnar and radial pulses. So in case you don't know what you're looking at or don't know in terms of terminology, dorsal is the back of your hand. Palmar or volar aspect, which can be confusing, is obviously the palm of your hand. And this relates to when we used to walk on all fours, so the palmar aspect would be the volar aspect. The proximal palmar crease is that crease where when you're applying a volar slab, that's the distal limit of your slab. So you don't want it to go further than that. And the reason for that is because the metacarpal head of the index finger is in that position. So when you examine the patient's hands, try and imagine what you're feeling underneath. So feeling for the radial styloid, ulnar styloid, carpal bones, and then try and picture the anatomy of the metacarpal and phalanges underneath your fingers. All right, so hand examination, part of the hand examination is assessing finger alignment. So so what's presented here is the patient has their metacarpal phalangeal joints, so their knuckles are flexed at 90 degrees. The proximal interphalangeal joints are flexed again. Or you can do this on yourself right now. With your knuckles flexed and your fingers flexed, your fingertips should point to your scaphoid or radial styloid. And that's normal finger alignment. If there's a malrotation, either in the proximal phalanx or the head of the metacarpal, you might have malalignment, in which case one of the fingertips will point skew, not at the radial styloid or scaphoid bone. Okay, so that's a warning sign. With the metacarpal phalangeal joints extended, so at 0 degrees, and the proximal interphalangeal joints flexed, the fingers should form a nice straight line. Okay, so you look at your own fingernails and they should follow the same plane. If you have malrotation or rotational deformity in your proximal or in one of the phalanges in the fingers, you'll find that one nail might be off. So that third digit is skewed. Okay, so that needs to be reduced, usually by surgery. Going on to surface anatomy, so obviously the knuckles and the dorsum of the hand we're all familiar with. Distus tubercle on the distal radius, anatomical snuff box, radial styloid. On the palm of your hand, you can feel it's important to know what you're feeling underneath the palm. So on the lateral aspect, we want to identify the scaphoid tubercle, pisiform on the medial aspect, and the hook of the hamate, which is deeper into the palm. So pain over those areas would prompt further investigation on x-rays. So when you're assessing flexor tendons, make sure you assess both the FDS, or the flexor digitorum superficialis, and the FDP. So FDS attaches proximally, so at the middle phalanx, and this is assessed by holding the, say for instance, we're assessing the middle or the middle finger, hold the index and the ring finger down, and then ask the patient to flex the finger towards the palm. That's assessing the FDS. FDP is you stabilize the middle phalanx and you ask the patient to flex the finger, and because the FDP inserts at the distal phalanx, they should only flex their distal phalanx. Remember, the thumb also has a flexor tendon, so you need to assess that as well, flexor pollicis longus. When assessing extensor tendons, make sure that you're assessing the extensor digitorum communis, as well as the extensor tendons of the thumb. Remember that the index and the fifth digit have dual extensors, and you need to assess those as well. Okay, when it comes to testing median nerve function, okay, you can ask the patient to make the OK sign, so they can oppose the thumb and the index finger, and they must oppose the thumb and the fifth digit as well. When testing sensation, you can check the light touch to the index finger, the dorsal aspect of the index finger. Radial nerve, radial nerve supplies the extensor compartment of the arm, the forearm, sorry, and it's also responsible for thumb extension. So ask them to give you a thumbs up and also to wave their hand. If they can do that, then the radial nerve is intact. The radial nerve can assess for light touch over the dorsum of the first interspace. When it comes to ulnar nerve motor function, ask them to abduct their fingers, abductions, so ask them to spread out their fingers, and then crisscross their fingers as well. And then to check ulnar nerve sensation, just touch the inside of their fifth digit or the pinky finger. Remember, there's a good arterial supply to the hand as well. The hand needs good arterial supply because it has a high metabolic demand because of the bony and muscular architecture. There's a robust collateral network, okay, comprising the superficial and deep palmar arches. The superficial palmar arch gives rise to the palmar digital arteries, which supply the fingers. Remember that 20% of the population have interrupted or incomplete superficial palmar arch. So when assessing for vascular supply, just check the pulses on both sides, check capillary refill in the fingers, check the temperature of the hand, and then also check the color as well. Okay, I'm going to talk briefly about imaging of the hand. Okay, obviously imaging modalities include X-rays, which are the most common imaging modality that we have available. Most hand X-rays include an AP, a lateral, and in some cases an oblique view. And then there's specific views as well, so scaphoid, clenched fist, and then thumb injuries should have a thumb view as well. Ultrasound can be used for assessing tendon injuries, vascular injuries, and in some cases it's been described for assessing bony injuries like scaphoid fractures, although the pickup rate for ultrasound in scaphoid injuries is quite low, so I wouldn't advise it. CTs we wouldn't really routinely do from an EC point of view. These are where CT would be requested when X-rays are non-diagnostic, when the patient has persistent pain. And then MRI is hardly ever used. So AP of the hand, AP X-ray of the hand is placed flat or as flat as possible, and that gives us our standard AP view. We want to see the radius and the ulna as well as the nice layout of the carpal bones. And I'll talk more about that now. So when you have a good AP view, you want to make sure that the carpal bones, the proximal row and the distal row are in alignment. We call these the carpal arcs. There's arc 1, 2, and 3. The first arc is looking at the proximal surface of the proximal row of the carpal bones. Arc number 2 is the distal articular surface, the proximal row of carpal bones. And then arc 3 is the articular surface of the distal row of carpal bones. And we just need to know that those arcs line up, that they look symmetrical and smooth, that there's no disjoint, there's no break in the continuity of the arcs. So carpal bones, we all learned some variation of a mnemonic in medical school. I learned some Laverstrap positions that they can't handle, and that's starting at the scaphoid on the lateral aspect, moving along the proximal row, scaphoid, lunate, triquetrum, pisiform, and then starting at, excuse me, the trapezium at the thumb, and then moving it laterally as well. So it's nice to know, it's nice to have a mnemonic to remember, so that you can identify which bone you're looking at. Just in general, carpal bones should be less than 2 millimeters apart, 2 millimeters or more. Worry about a ligamentous disruption or a fracture. Okay, so normal carpal spaces should be less than 2 millimeters. What else can we see on the AP of the wrist? Well, one of the things that we do look at is radial length and radial inclination. So to assess these two measurements, what you need to do is draw a line through the long axis of the radius. So that's line number 1 through the long axis, so parallel. The second line is 90 degrees to the long axis through the tip of the radial styloid. So that's line number 2. The third line is another perpendicular line to the long axis through the distal or the proximal articular surface of the radius, and it should involve the ulnar head as well. And what you do is you measure the distance between those two lines, and that gives you the radial length, which is a plus minus 11 millimeters. And you can imagine with a compression fracture, perhaps a Colles fracture, where that distal radius is impacted into the body of the radius, you'll have radial head shortening. So that radial length will be lower than expected. To assess radial inclination, you draw a line between the proximal and distal edges of the articular surface of the radius, and where that crosses that perpendicular, you want to get an angle of about 22 degrees. And that's important for post-reduction X-rays. So if you reduce that Colles fracture properly, is that radial head in reasonable alignment? So you can imagine with an impacted fracture that you're going to have a smaller angle compared to normal. Okay, looking at the lateral X-ray of the hand, so the hand is placed with the thumb slightly abducted, okay, and that gives us a view through our carpal bones. And I'll talk about alignment, what we want to see on the lateral hand. So in terms of the lateral hand, we want to make sure that the radius, the lunate, the capitate, and the third metacarpal are in some sort of alignment, so they should follow a straight line. That all contours are smooth and that there's no visible irregularities. Obviously, if there's any irregularities that we're concerned about, we need to worry about a fracture. There are derivative measurements. I would encourage you all to have a look at these measurements and just to give you a better insight as to what else is used to determine, you know, other more subtle, rarer injuries. So radiopalmar tilt, scaphoid axis, the lunar axis, scapholunate angle, and interestingly, dorsal intercalated segment instability and volar intercalated segment instability for assessing weird injuries like lunar triquetral ligament injuries. I'm not going to cover those in this lecture though. All right, so let's get to the beef of the lecture. I'm going to talk about some common hand injuries. So let's speak about carpal bone injuries. So obviously the most common carpal bone that's injured is the scaphoid bone. It's prone to avascular necrosis, non-union, it's scapholunate collapse. So how do we examine a patient for a possible scaphoid injury? We assess for anatomic snuff box point tenderness. We can assess the scaphoid tubercle, and then we do what's called telescoping of the scaphoid or a scaphoid compression test. Please, you need to get standard wrist views of if you suspect a scaphoid injury, plus a scaphoid view. All a scaphoid view is, it's an AP with a wrist and ulnar deviation, so it helps to open up that scaphoid. Remember, we might not see an initial fracture in 25% of patients, so if in doubt, if you're worried about a possible scaphoid injury, rather apply a thumb spiker and re-x-ray the patient in 7 to 10 days. Sometimes those fractures then show up. Obviously, for confirmed fractures, you want to apply a thumb spiker. These fractures tend to complicate if they are not immobilized early. So specific tests for scaphoid, so for scaphoid fractures, from A to C, A is more sensitive, whereas C is more specific for scaphoid fracture. So remember, there's a lot of structures in the anatomical snuff box. It's not only the scaphoid, there's arteries, veins, and multiple tendons and ligaments. So here he's examining, or she is examining this anatomic snuff box with the thumb. I would advise using the pinky finger and just pressing over the scaphoid bone for tenderness. Palpation of the scaphoid tubercle is more specific than anatomic snuff box sensitive tenderness. And then scaphoid compression is when the examiner holds the patient's thumb in their hand and with the thumb slightly abducted, compress the metacarpal, the first metacarpal against the scaphoid. And if you have tenderness of the scaphoid, that's more specific for a scaphoid injury. Just remember, if they've got a metacarpal fracture of their thumb, then that's going to give you a false positive. So in terms of vascular supply, we can see that the proximal scaphoid has limited vascular supply. So distal tubercle and waist fractures of the scaphoid tend to heal well, whereas the proximal pole is at risk of avascular necrosis. Okay, triquetrum fractures. These are the second most common injured carpal bone after the scaphoid. The incidence of triquetrum fractures is about 3% of wrist injuries, so they're not very common. Generally, the mechanism of injury is a fall on an outstretched hand with wrist hyperextension and ulnar deviation. There's 3 types of fractures. About 90% of these injuries are dorsal avulsion fractures, which we see a pooping duck sign on the lateral X-ray. I'll explain that now. Triquetral body fractures and then volar avulsions are quite rare. So if the triquetral body fractures and volar avulsions are usually associated with ligamentous, radial ulnar, or other carpal injuries, and these need to be assessed or to be tested for. Most cases, management is quite conservative, so volar splint for 4 to 6 weeks. If there's persistent pain or ligamentous instability, these usually require surgery. So you can see AP and lateral view of the wrist. So the pooping duck sign, so what that is it's the scaphoid. On the lateral make up the head and neck of the duck. The lunate makes up the body and wings, and then the triquetral body makes up the tail. We generally don't see the triquetral on the lateral x-ray because it's overshadowed by the scaphoid and the pisiform. And then this dorsal avulsion fracture is the poop of the duck. So there's my attempt at drawing a duck, and that's the avulsion fracture, which is the poop. The AP of the wrist it looks plumb normal. So why we want to assess the AP is to make sure that there aren't associated ligamentous tears or other injuries. So there's the pooping duck. So this is important because the ulnar triquetral ligament attaches to this little fragment of bone, and if that fragment is quite significantly displaced or there are associated body fractures, we need to think about other ligament tears. Okay, moving on, scapholunate dissociation. So this young man, or this man in this picture, this is Terry Thomas. He was a British comedian who's now passed on. He was famous for this big gap between his teeth, for which the X-ray sign of scapholunate dissociation is named after. So there is a widened joint space between the scaphoid and the lunate of more than 4 millimeters on the PA view. And that's due to an injury of the scapholunate interosseous ligament. It's usually a high impact fall on an outstretched hand with hyperextension and ulnar deviation. Patients have tenderness, swelling, decreased range of motion. You need to assess for a scaphoid injury as well, scaphoid fracture. And in these cases, apply a thumb spiker, and they need a non-urgent referral to hands. So it's the Terry Thomas sign, which is seen on the AP or PA, and that's the widened scapholunate distance of more than 4 millimeters. So perilunate and lunate dislocations are discussed together because the X-ray findings are very similar and the mechanisms of injury are quite similar, and they're managed in relatively the same way. These are also due to high impact fall on outstretched hand with wrist hyperextension. Again, tenderness of the scapholunate joint, pain, swelling, decreased range of motion. With a perilunate dislocation, what that means is dislocation of the capitate. So the capitate is usually displaced dorsally while the lunate retains alignment with the radius. In lunate dislocation, the lunate is dislocated, usually in a palmar direction, whereas the capitate retains alignment with the radius and the metacarpals. Closed reduction is quite difficult for both these conditions, so your best bet is to apply a splint, usually a volar splint, and urgent referral to hands for reductions necessary. So here you can see this would be a lateral view of the wrist. So in perilunate dislocation, the capitate is dislocated, so usually dorsal, and the lunate retains its alignment with the radius. In lunate dislocation, the capitate retains its alignment with the radius, but the lunate spills forward, and this we call the spilled teacup sign, which I'll show you an example of on X-ray. So perilunate dislocation. So here we have AP and 2 laterals. So as I've mentioned previously, the capitate is displaced dorsally, the lunate and the radius are still in alignment, and that you can see on this X-ray here. On the AP view, however, we have what's called a jumbled carpus sign. So we can see disruption of the carpal arcs, so that those beautiful lines I showed you earlier on, they are all jumbled up here. You can see the proximal and distal row of carpal bones are overlapping, and that's because of this capitate that's been pushed dorsally. Cool. So this is quite a similar X-ray to previous, but it's actually a lunate dislocation. So here you can see on the lateral aspect, the capitate and the radius are in alignment, but the lunate itself is spilled forward. We call that the spilled teacup sign. So on AP view, because the lunate kind of shifts forward and rotates at the same time, it gives us what's called the pie in the sky sign. That's only seen on the AP view, and it's because the lunate overlaps the capitate. It's abnormally rotated. On the lateral view, we have a spilled teacup sign. Okay, and that's because the lunate is dislocated forward. Cool. All right. I'm going to briefly talk about, let's talk about tendon injuries. So tendon injuries are quite common. Remember to always assess for the FDS and the FTP. So when the FTP is avulsed, we call that a jersey finger. The mechanism of injury is when somebody's been holding onto, say in a rugby tackle, they're gripping onto a player's jersey. Player runs away, their hand is forcefully flexed, but their finger is forcefully extended away. And we have avulsion of the FTP from its insertion point. So we call that a jersey finger, named after, because it's a rugby jersey injury. On the X-ray here, you can see avulsion fragments of the FTP of, it looks like the middle and ring fingers. Patients might present with bruising of the distal phalanx. Okay. And they have absent flexion of the distal phalanx. Okay, so when you assess for the FTP, they won't have any flexion here. We can do an ultrasound to confirm a fracture, or to confirm tendon avulsion, and X-rays may show us a fracture. These can be buddy strapped. In some cases, we would apply a mallet splint to that finger just to keep that finger in slight flexion. And they need non-urgent referral to hands to fix those tendons. The mallet finger is a force applied to a extended finger. So it's the avulsion of the extensor tendon at the dorsal aspect of the distal phalanx, and they might have associated fractures. So when the finger is extended, but there's forceful flexion applied, so say, for instance, the finger's caught in the door, they might have avulsion of that extensor tendon. They would have absent extension of the distal interphalangeal joint, and the fingers might be held in flexion, as depicted in the picture below. Again, ultrasound can confirm tendon avulsion. X-rays might show fracture. These guys need to be splinted with the distal phalanx in extension, and they need to be referred to hands if there's a large avulsion fragment, or if they have persistent volar subluxation of the distal phalanx, even with splinting. Gamekeeper's thumb is an uncommon injury, but it's something which is potentially quite debilitating. So this is disruption of the ulnar collateral ligament of the thumb due to forced extension or abduction of the thumb metacarpophalangeal joint. So it's I could also call it skier's thumb, where the ski pole of the patient's thumb is pushed against the person's thumb and forcing that thumb into that abduction extension. What they have is a partial complete tear of the ulnar collateral ligament, which results in an unstable pinch mechanism. So when you pinch your fingers together, you have the radial collateral ligament of the index finger and the ulnar collateral ligament of the thumb working together to give you a stable pinch mechanism. So if that ulnar collateral ligament is disrupted, patient won't be able to get a good solid grip. They might have pain, swelling, bruising, or palpable lump, in which case we'd be concerned about a Steiner lesion. How to assess for ulnar collateral ligament injury is you want to have the thumb mildly flexed and then apply radial stress. Okay, so you want to exacerbate the injury and see if there's any laxity. Ligament laxity of more than 15 degrees in comparison to the normal side would be diagnostic for an ulnar collateral ligament injury. So for partial and stable tears, you can do conservative treatment, which is thumb spiker. And for unstable injuries, avulsion fractures, or if you have a Steiner lesion, you would refer these guys to hands. Steiner lesion is impingement of the thumb adductor tendon inside that ulnar collateral ligament. So they have impingement of that joint, which needs to be surgically corrected. All right. I'm not going to talk about metacarpal fractures for the sake of time. I want to talk about fingertip injuries and mammalian bites. So in terms of fingertip injuries, I've included this because it's quite a common presentation that we see. A lot of our manual laborers and workers might present to the emergency center with fingertip injuries. And they're important to know how to manage properly, because there's different injuries that can present. In terms of fingertip anatomy, it's quite a complex structure for such a small space. Obviously, the nail itself, looking at the dorsum of the nail, you're familiar with the lunula, which gives you an idea of where the germinal matrix of the nail is. And this is important because that's the part of the nail that actively grows and makes nail. So if that part of the nail, part of the finger is damaged, patients might have disrupted nail growth. On the lateral aspect, you can see the distal phalanx is right underneath that nail. We have the germinal matrix and the sterile matrix. If you have to suture a nail bed laceration, remember you need to align the nail bed properly so that the patient doesn't have deformed nails for posterity. The extensor tendon insertion and the flexor tendon insertion are quite close by to that nail, so with nail avulsions and distal phalanx fractures, there can be associated tendon injuries as well. Okay, so something that we commonly see, avulsion of the digital pulp. So these guys present following shearing force or lacerations. That, for instance, somebody's chopping onions or working in the kitchen, they accidentally slice the tip of their finger. That's just a bit of skin that's been avulsed. These are very simple to treat, but bleeding can be difficult to control. So there's a couple of methods. One is to use the finger of a glove, which, so you just remove the glove of the finger, finger of the glove, make a small hole in the tip of the glove, and then you roll this along the patient's finger, and this gives you an instant tourniquet. What you can also do is soak the fingertip in lignocaine with adrenaline, so you can take a couple of amps of xylotox, put it in a specimen container, and ask the patient to dip the finger in that for a couple of minutes, and the adrenaline will have vasoconstrictive effects. So that helps as well to stop bleeding. And then what you can also use is a silver nitrate applicator, the same sticks that we use for epistaxis. You can actually just gently cauterize the tip of the finger to stop bleeding. All these guys need are paraffin gauze dressings, so something moist, so that when you remove the dressing, you're not pulling off all the new epithelium. And these heal very well without further intervention. So you don't need to splint them, you don't need to refer them, unless there are associated injuries, which I'll talk about. And the wounds are allowed to heal by secondary intention, so no suturing is required. So commonly distal phalanx fractures we see often. So a person gets their fingers caught in a car door. They present with a big bruised swollen nail. These are commonly associated with nail avulsions, so make sure that you check for nail bed lacerations as well. If they have a subungual hematoma, which I'll talk about soon, you need to manage those as well. These are quite simple to treat, so if it's a closed tuft fracture, so no other nail avulsion or open lacerations, give analgesia, splint, so you can apply just a mallet splint to immobilize the distal interphalangeal joint, 2 to 3 weeks. If the fracture is extra-articular, like the X-ray shown, they don't need referral. If the fracture is intra-articular involving that distal interphalangeal joint, if the fracture is comminuted or if there's associated tendon injury, these guys need to be referred. If there's an open tuft fracture, so if there's a nail avulsion or open injury, give them analgesia, apply digital block. You need to irrigate those lacerations with pressure, suture the wound, and realign the nail if possible, and then splint the distal interphalangeal joint for 2 to 3 weeks. If the wound is contaminated, you can give antibiotics. and these guys need to follow up with hands or have good follow-up so that you can assess now, do a wound check and assess for whether there's any complications associated with that wound. So something we might see commonly as well is a nail avulsion with a nail bed laceration. So these guys could also have their fingers caught in the door, that they pull the finger out the door, commonly crushing injuries as well. So here the nail is torn away from the nail bed, the nail fold. The problem with these injuries is that if they're not repaired properly and realigned properly, they can have disturbed nail bed or nail regrowth, and they're also prone to infection. Some of these are prone to distal tuft fractures as well, which I've spoken about. So for these guys, analgesia, a simple digital nerve block, and X-rays are necessary. So you need to irrigate these under pressure. It's not enough to just dip their fingers in a bowl of betadine, iodine. It's not enough to do that. You actually need to sit and irrigate their fingers under pressure. I'll show you a method to do that soon. That fingertip needs to be realigned. So usually we suture the fingertip and we place the nail back under the nail fold. If the nail is completely avulsed, that nail needs to be put back under the nail fold, and then the nail needs to be secured in place, either by suturing through the nail or suturing, making a figure of 8 suture along the nail. I'll show you some examples of that. We can use skin glue if you have it available to suture the nail bed. Secure the nail bed. Otherwise, absorbable sutures to the nail bed, followed by replacing the nail. I've spoken about that. If the nail is lost, you can use like a nail prosthesis. So either a piece of foil splint, so you can cut the suture packet into the shape of a nail, place that into the nail fold. You can also use sterile plastic. Again, paraffin gauze dressing, and these guys need a digital splint to keep everything in place. And generally, they would be referred to hands for further management. So below you can see this. This is an intact nail which has been replaced. So what they've done is they've snipped 2 wedges into the distal nail edge, and they've placed just a suture through the paranechium, both sides. So it's a figure of 8, in and out, along those wedges to secure the nail, and then in again and then secured in the middle. So that's a figure of 8, which applies lateral tension as well as tension in the proximal direction. So that keeps the nail in place. There's different methods of securing the nail. You can make holes in the nail before replacing the nail. So with the needle, make 2 holes on either side just to make it easier for your needle to pass through. Nails are quite hard to suture. Here's a foil prosthesis, and here's a plastic prosthesis. Remember, these need to be changed. So if the nail is intact, please use the nail. If you don't have the nail, use the prostheses. But remember, these need to be replaced every 2 to 3 days, which is quite cumbersome. Okay, so subungual hematoma, all that means is bleeding underneath the nail. Very, very common, okay. In most cases, they are managed very conservatively. We do need to do X-rays to exclude a distal phalanx fracture. If the patients have no or very little pain and the hematoma is small, give them a strong handshake and tell them to carry on with their lives. If they have moderate pain, or if it's a large hematoma, what you can do is nail trephination. And what this is either using cautery or a needle to make a small hole into the proximal nail to allow that blood to be expressed. Once the blood is released, you can clean the nail and leave it resting on for 7 to 10 days. And generally, these guys do quite well. So here you can see cautery units. So some people talk about a nail clip, or cautery. So if you have a very small cautery needle, you can use that as well, just to burn through the nail. Not too much pressure, because you don't want to burn or injure the nail bed that lies just beneath that. Just to make a hole in the nail, and then you express the blood out. What I've used is a 23, 20 or 20 gauge needle, and then gently in a kind of twisting motion just to make a small hole in the nail. and that then allows that blood to seep out. These guys just need a simple dressing and they can follow up with the peri-hospital GP. So in some cases we might see amputation of the fingertip. So some people might have power tool injuries, or chefs we commonly see who aren't looking what they're doing. They might cut off the distal part of their finger. These might also be associated with shearing forces or crush injuries, in which case you might have an avulsed or partially amputated fingertip with associated fractures. So management would depend on the amount of tissue loss and whether the bone is exposed or not. Generally speaking, if there's minimal tissue loss and there's no bone exposure, you can treat these like you would a fingertip avulsion injury. So we manage them as a pulp avulsion, so give them analgesia, make sure the wound is clean, update their tetanus immunization, and we leave these wounds to heal by secondary intention. Okay, so because the epithelium is still intact around the sides, these would generally heal quite well with very minimal scarring. Because in this case, the nail bed is still intact, that nail should grow normally in a couple of months' time. If there's significant tissue loss or bone is exposed, you need to manage these as an open fracture. So analgesia, give them a digital nerve block, irrigate these under pressure, give them paraffin gauze dressing. If the fingertip is potentially salvageable, you need to put that fingertip or that part into a plastic bag, and then put that plastic bag, once it's sealed, into another plastic bag containing ice and water. And then you seal that, and you note the time and dates that you put the part into the water. The reason why you don't want to put a fingertip directly onto ice is it's going to cause permanent damage from vasoconstriction. Give them prophylactic antibiotics, and then refer to hands emergently for possible reattachment of the fingertip. All right. Lastly, I want to talk about mammalian bites. So when I talk about mammalian bites, I'm talking about dogs, cats, and humans. So bites
Sorry to disturb. We just have our hands up before you continue.
Sure.
Hi, Paul. Sorry. Thanks again for the lecture. And sorry, my camera's not working, which is probably a good thing. So you mentioned the time with the putting the fingertip in a bag. Is there any kind of absolute cutoff where you're just not going to do it, or would you do it anyway? Like, kind of what's the kind of period that they've got to get it back on for orthos?
Look, I haven't found much evidence for time, but generally 6 hours is the kind of standard cutoff. Okay. The bigger the part, the more urgent the referral. So if it's just a slice of the fingertip and you're not too worried there's no bone exposure, I wouldn't worry about saving that part. If it's the whole finger, then I would, and it's within 6 hours, I would definitely refer. Even if it's after 6 hours, I'd still give the patient the benefit of the doubt, and I would refer them with the part in the bag.
Cool. Thank you very much.
Now, if the finger looks non-salvageable, if it's purple, rotting already with maggots, then I definitely wouldn't. I wouldn't try and salvage that part. But if it's fresh and the patient comes with a fingertip in like a serviette or a napkin, clean it, put it in a bag, and send them with it. I'd rather give them the benefit of the doubt.
Okay, thank you.
Generally about 6 hours, yeah, from what I've read. Cool. Any other questions? Okay, let me carry on. So bites, remember, can be tooth punctures. They can be associated with crush injuries as well as avulsion injuries if the animal takes a bite and then rips away. Mouths are generally quite dirty, and cats don't brush their teeth. So imagine polymicrobial injuries, so lots of contamination. Humans as well, staph, strep, Ichinella corrodens, quite common. Dogs have the above plus anaerobes and capnocytophagia, canimorphosis, and then Pasteurella canis. You don't have to worry about these. Cats, Pasteurella multicida is one of the common bugs that we see with cat bites. They have a high risk of infection, and just remember that they can transmit other diseases such as rabies and HIV, not from cats but from humans. And these are seemingly innocuous, so always be cautious about cat bites, dog bites. They can be much worse than what they initially look like. So management of bites just boils down to basic good wound care. So all bites are considered contaminated. All wounds must be cleaned and irrigated under pressure and explored, and that's important for wounds over tendon areas and joint areas. Tendons need to be visualized through full ranges of motion. So if, for instance, a cat bite close to the joint, you need to assess that joint in full range of motion. Foreign debris must be removed, bits of teeth, okay. Generally speaking, if the wound is fresh, so within 8 hours, if it's clean, if it's relatively superficial, and in some cases, cosmetically disfiguring wounds can be closed primarily. So that old adage of never suture a dog bite, there are exceptions to that rule. Otherwise, you'd leave a dog bite or a cat bite or a human bite to heal by secondary intention if the wounds are on the hands, around joints, or involving tendons. If the wounds are associated with crush or revulsion injuries, or any other wounds that you're afraid to suture primarily. You can consider delayed primary closure if follow-up is good. Delayed primary closure just refers to closing that wound 2 to 3 days down the line to assess if any infection has occurred and to assess wound healing. So what I've used to irrigate wounds is a 20 ml or 50 ml syringe with a 20 gauge or an 18 gauge needle, bigger the better. The syringe for volume, the needle for pressure. And this is a medicine cup I've just poked a hole in the back, and that acts as a splash guard. You can also use a sputum container as a splash guard. So this is a patient who unfortunately wasn't bitten, but he was assaulted and he's got a chin laceration, which we're irrigating. So you can see it here in practice. So here we're using 50 ml of tap water just to irrigate the wound under pressure. And in this procedure, you want to make sure that you're getting good pressure by seeing bubbles in that wound, so you get a nice good squeeze. And that splash guard helps prevent water from going everywhere. Okay, so fight bites, common. Okay, so sudden light injuries. So it's generally a clenched fist to patients, to the other person's mouth and teeth. As you can see here, teeth are then embedded into the patient's hand. They can have penetration of the metacarpal phalangeal joint as well as the extensor tendon. Unfortunately, if there's bacteria present in that wound, patient can disseminate that bacteria when they extend their hand or unclench that hand. So if the bacteria inoculated into the skin, when the patient then extends their finger, all that bacteria are then transmitted up into the rest of the patient's hand, and they can present delayed with quite extensive serious hand injuries. For these guys, good wound management is critical, so make sure that you explore the wound, wash the wound, give them prophylactic antibiotics. This is the one case where you definitely will give prophylactic antibiotics. These guys are prone to septic arthritis, tendon rupture, osteomyelitis if it's delayed infection, and also systemic infection. Imaging is essential as well as antibiotics. And these guys do need to be referred to hands for urgent exploration and washout if there's delayed presentation or if infection has already set in. Okay. So just briefly, antibiotics for bites need to be broad spectrum and they need to have anaerobic cover as well. This is actually a cat bite, which is now being complicated by hand sepsis. So generally, no penicillin allergy. So if patients have no allergy to penicillin, coamoxiclav, augmentin, amoxicillin plus clavulanic acid alone is fine. You don't need to give metronidazole. Coamoxiclav is good anaerobic cover by itself. If a patient is penicillin allergic, There's a couple of options. Clindamycin plus fluoroquinolone, like ciprofloxacin, is one option. Otherwise, something like cefuroxime, a second-generation cephalosporin plus flagyl for that anaerobic cover is also an option. You can use doxycycline or Bactrim alone, although the cover isn't as extensive. If you are giving antibiotics for prophylaxis, 3 to 5 days is fine. For treatment, 5 to 7 days. All right. I think I'm going to end off there. Just to sum up, remember from our best practice, hands are livelihood. Always remember to get a mechanism of injury. Ask about hand dominance. Give analgesia early. Consider local blocks. You need to know your anatomy when you examine the hand. Always get x-rays and ask for specific views. Remember to irrigate and explore wounds, especially bites. Splint and elevate the limb. And when in doubt, ask for assistance if you're not sure about refer, but always consider early referral. Thank you. Are there any other questions?
Thank you, Paul. Thank you so much. No questions currently on the chat and no hands raised. Thank you so much for your presentation, and especially thank you for the tips and tricks of the trade. Very useful ones that came through. Just one in the chat, let me just see. Yeah, not a question at the moment. Thank you so much for the Vic Consultants team. You guys have really managed to get the orthopedics topic across for us. COVID-19 has presented us with a lot of technological challenges, but also advances. So thank you for Flip for that poll. That was an interesting experience and it worked out quite well. We hope to see you again on this platform. We really appreciate this teaching. Thank you so much.
Thanks, guys. Good afternoon.
Paul, have you left? Are you still on?
No, I'm still here.
There's one question. Question. It's from Neville, and he asks, which extensor tendon injuries are said to suture?
Okay, generally, so extensor tendon injuries safe to suture. It really depends. So I generally would speak to my friendly orthopedic or hand surgeon before suturing an extensor tendon injury. From the literature, less than 50%, if the extensor tendon is less than 50% severed, less than 50%, those don't need to be sutured. More than 50% needs to be sutured. And there's different methods of suturing. Depends if you can find the tendon injury, but generally speaking, for extensor tendons, you know, anything from proximal phalanx of the metacarpals as well, you could potentially suture. But I would speak to the person on for hands first. The caveat to that is, do not ever suture or try and suture flexor tendon injuries. Okay, those are notoriously difficult. The problem with a flexor tendon injury, especially if there's a complete rupture, is that they tend to track up into the palm or into the forearm, and you have to try and find that tendon. Don't do it. It's not worth it. Rather refer.